Hello, I'm Professor John Gribben from Barts Cancer Institute in London. We're at the American Society of Hematology meeting in San Francisco. I'm joined by my good friend, Professor Peter Hillmen from Leeds. And we're here to talk about some of the things that we've seen here that are very exciting at the meeting. Mm-hmm. So the first kind of thing that one of the first talks we saw in the first clinical session, of course, was the further update of the CLL TenMeet study. Mm-hmm. Now, what patients are looking for is how do we get the best therapy with the least toxicity? How do you interpret the balance between the efficacy of FCR with the decreased toxicity of bendamustine and rituximab?
I mean, the CLL TEN trial was designed as a non-inferiority design, so is BR as effective as FCR? And the trial has clearly shown, I think, in patients who are fit for FCR, that FCR is superior in terms of progression-free survival and in depth of remission that's achieved. There is a penalty to pay, and that's the penalty is infections and more neutropenia, but that is largely manageable. I think the question we have left within that sphere is the more elderly patients who we consider fit. How do we define
who those patients are?
Exactly.
The problem we have right now is the trials haven't been designed to ask that question in quite the right way. Mm-hmm. By doing the study against patients who are fit for FCR, only those patients who are FCR eligible were included in the study. Yeah. But is your interpretation of that data that if somebody's fit for FCR, that remains the optimal therapy?
I think so. Certainly at the moment that's the case, and we have ongoing studies in the UK, as you know, comparing bendamustine with ofatumumab with chlorambucil ofatumumab plus or minus idella, and I think those are really key questions that we need to address to look at the place of bendamustine plus CD20 antibody in the chemotherapy sort of setting, and which patients we should treat with that agent.
Sure. The other thing that we saw reported this year was the use of, well, you can call it consolidation or maintenance, but the use of anti-CD20 monoclonal antibodies after completion of chemotherapy. What do you make of those trials that were reported?
So I mean, the use of CD20 antibodies, rituximab, ofatumumab, as maintenance, of course, follows follicular lymphoma, where it's become a standard in other indolent lymphomas, and we've had concerns, of course, in CLL that the CLL is not the same as indolent lymphomas. We see more infections. We don't want the immune suppression that you might see. Both trials have shown a very positive response in terms of progression-free survival and actually delaying the time to next treatment or relapse. But the penalty that's paid is a high risk of infections during the treatment, and we don't have overall survival data, and we are giving patients infusions for every 3 months for 2 years in both those trials. So there's a penalty to pay in terms of the patient would be off treatment otherwise and not coming to the hospital being treated. And so I think it's immature yet to interpret either of those two trials that we should be changing to a CD20 maintenance. We'll need to see much longer follow-up survival differences over a period of time before the cost in terms of patient inconvenience and infections justifies using that approach.
So on the theme of cost, of course, the other thing we've seen much more of are the novel agents, namely ibrutinib, idelalisib, rituximab, as well as actually a whole variety of other compounds working in those same sorts of pathways. There's a huge patient interest in the so-called chemo-free approach. For your patients that come to you saying they'd like to avoid chemotherapy, what's the advice that you give them as to why we should wait for the results of clinical trials?
We just don't have any long-term data in these patients. I mean, so with these therapies in the frontline setting, certainly in patients who are fit for FCR, who can tolerate treatment, we have patients, and there's data that's been shown recently and at this meeting to some extent, where a proportion of patients with FCR are in remission at 10 years and beyond, and are being seen by the doctor every 6 months and are forgetting about their CLL. And part of the cost we pay by using novel agents is that they will remain on therapy at risk of any complications and see us more regularly, which I'm sure is not always a good thing. So the data for the frontline, both idelalisib plus rituximab and ibrutinib, is encouraging. We're seeing at a relatively early stage, 2 to 3 years, most people remain in remission, tolerating the treatment well, and it appears that these drugs are even more tolerable in the earlier on in the disease course. But we really need to see the comparative trials, and we have those trials open now. We in the UK we have one of the biggest trial of ibrutinib rituximab in frontline versus FCR,
and which will answer the question
precisely. So
sure.
We must encourage our patients to consider those trials as an appropriate way to be monitored and treated.
Now the other, of course, group of patients which historically we've always worried are those patients with 17p. So we've seen some 17p specific trials here, again confirming what we already knew from the previous trials, that is that these novel agents appear to be able to largely overcome many of the adverse prognostic impact of those studies. So what do you make of the studies that you've seen here at ASH this year?
So, I mean, first of all, the allogeneic rituximab, the maturation of that trial, which was reported a year ago for the first time, we've seen data at this meeting that the patients with 17p, p53 mutation and 11q, so the poorest patients, do equally well with that combination as those who don't have that.
So it's no longer a poor prognostic marker
in that
setting. Sure.
And then we have a large trial, which we in the UK were very active in recruiting into, of patients who had relapsed with 17p deletion treated with ibrutinib, so 144 patients, and that we see the early data, granted, but very encouraging data out at a median of about just under a year's follow-up, that most patients are doing very well with that combination. Having said that, there was some of the more mature data from the phase 1, phase 2, so the earlier trials, does suggest that as we get out to 2 or 3 years, those prognostic markers, at least in the relapsed refractory patients, are still, those patients are more likely to relapse through ibrutinib, for example. And so we still have an unmet need, I think, that we need to look at combinations, and I'm sure we'll talk about ABC 199 and how that may add to the party, if you like.
Sure. So in terms of, so for those patients who are young enough and have a donor to consider an allogeneic transplant with a 17p deletion, are you yet seeing data that would make you think you should remain on a novel agent rather than have a transplant, or what's your? It's very controversial.
Absolutely, it's a really difficult question, really, for both ourselves and for patients who are obviously in that position. We've had a debate this morning regarding the European Research Initiative on CLL, ERIC, regarding an allo transplant trial, and it's really difficult to do trials where you randomise a patient to a tablet capsule, which they tolerate well, or an allogeneic transplant. And I think the setting, allogeneic transplant, it still has a role in CLL, but we don't really know where the role is. And,
sure.
And my experience, most patients, if they're responding well to ibrutinib or to one of the other agents, you tend to delay the transplant, even if we would be trying to say, well,
it may happen eventually, but let's put it off longer.